case. Our next speaker is Dr. Ravindra Mohan, who would be detailing on his most difficult case. Dr. Ravindra Mohan, sir, over to you.
Okay, am I visible, audible?
Yes, yes.
Yes, okay. Right. Now, this was obviously a difficult topic to speak on because in the end, the most difficult case is one where we are completely stretched out and not knowing what to do despite decades of experience and so many meetings and webinars and discussions. So what I'm going to essentially talk about is something which is a kind of a situation which I've never experienced in my entire professional career. And I'm sure many of you would not have also. Right. Now, briefly, what are the stages of development of a surgeon? In the first few years, we learn how to operate. Then for the next few years, we learn when to operate. Then we come to a stage where we are mature enough, wise, and we know when not to operate, which are the kind of cases we are not going to touch because that's going to be, the outcome is going to be worse than the disease. And then comes possibly once in a lifetime or once in a career or once in a decade, a case like the one that I'm going to now present. Now, let's call her patient X. She was a 63-year-old lady and unusual and challenging in many ways. She had COVID in August of 2020, was home cared, no steroids, no oxygen, non-diabetic. She presented with earaches for past 8 months, right-sided severe facial pain, facial swelling, and loss of vision of a catastrophic nature with findings of acute orbital cellulitis. So she was admitted to the ICU in one of the multi-specialty hospitals I'm associated with, and my ophthalmology junior colleague was called in to see the patient urgently one evening. The MRI right side showed medial orbital findings with focal cerebritis, a diffuse sinus mucosal thickening. And this was managed like in any situation. There was nothing in the history to suggest at that time remotely of anything other than an infection from the ear or thereabouts entering into the orbit through some of the venous channels and also causing focal cerebritis. So, and sinusitis in the setting of sinusitis. So she was managed as orbital cellulitis till on the second day, after 2 days, there was catastrophic loss of vision in the second eye. And this was nil perception of light vision. So here we are trying to manage the first eye as orbital cellulitis, patient is stabilizing, and then all of a sudden the patient says that she can't see and she's nil perception of light vision. And fundus examination showed a pale, non-perfused retina. It was at that time that we for the first time considered the possibility of an orbital infarction going on bilaterally at this time. The first time was nil perception of light at admission itself. There was absolutely no suspicious findings of ROCM or mucormycosis or nasal endoscopy, which was done by a very senior ENT surgeon. As the patient evolved, clinically, the cavernous sinus showed some evidence of thrombosis or inflammation. So given the clinical situation, we thought of cavernous sinus thrombosis resulting from either ear or a sinus origin going on to an orbital cellulitis. She was absolutely non-responsive to aggressive medical therapy under a multidisciplinary team. And the ESR was raised to the extent of about 125 millimeter in the first hour. So many possibilities were considered, which included vaginous granulomatosis. And to add to the confusion, the urine also showed some proteins. So there is orbit, there is vascular blocks, vasculitis, something going on, and kidney involvement. A blind orbital exploration. So we had a multidisciplinary meeting and we looked at all the options, and the patient was obviously going downhill very rapidly. So I proposed a blind orbital exploration and proceed. I mean, there was no other tissue which was so involved, and there was no other tissue which was accessible either. So I performed a transconjunctival approach orbitotomy and wide exploration uh, under general anesthesia. What was very striking at this point of time was it was a completely bloodless surgical field. There was absolutely no bleeding. I mean, it was almost like operating on a cadaver. And in fact, I asked my neuroanesthesia anesthetists who were in charge of the case whether they had given hypotensive anesthesia, which they denied. No necrosis was noted. There was nothing like an eschar. There was nothing like anything abnormal except that it was a completely bloodless field. So I took multiple biopsies, not knowing where I was heading, flying blind in a way of speaking. I took multiple biopsies from the fat, the medial rectus muscle, lacrimal gland, and I also sent it for primarily for pathology, but some of it for microbiology as well, because it could be infective. I mean, at that time, Nuker was just about raising his head, but this was very, very atypical by any stretch of imagination. So the ENT surgeon again did a diagnostic nasal endoscopy. Intraoperatively findings was earlier, nothing to, a biopsy, nothing to do. So histopathology and microbiology finally provided us a clue to the diagnosis. This is patient just before I performed the orbital surgery. One can see the pupils are mid-dilated, fixed on both sides. And it's the right orbit which was initially involved, which I went ahead and did a transconjunctival biopsy. Now this is the congestive signs in the eye. And this is early orbital involvement, which is fairly subtle, which one can find that there is some amount of, the medial recti are standing out a little bit, but otherwise things are not very remarkable in that. Now, what did the biopsy show? It showed vasculitis-like features with destruction of capillary wall by neutrophils and surrounding necrosis. No fungus was identified at this stage. So in the light of this finding and raised ESR of 125, etc., the rheumatologist was called in and who looked at everything and considered the diagnosis of vaginous granulomatosis. So that was considered only for half a day. With the diagnosis of vaginous granulomatous, the pros and cons of steroids and immunosuppression was still being discussed till the orbital tissue KOH mount showed broad aseptate hyphae at right angles. And the diagnosis was very clear.
So you have 1 minute remaining, sir.
Yes, I'm just finishing. So at right angles. So lactophenol cotton blue showed what was very typical. Fungus was identified. The stormy course with the brain abscess, parotid and neck abscesses, enterococcus, bacteremia. She underwent a craniotomy and excision of the abscess, pan-sinus endoscopic debridement of whatever was seen, repeated drainage of neck and other site abscesses, left hospital after 5 weeks alive and comfortable, except that she was blind in both eyes, and these are to show the neck abscesses. These are the later images which show much more developed findings both in the CNS and in the orbit. And also the bone which was removed, which was a little unhealthy during the craniotomy, showed the same kind of aseptate fungal hyphae, which one can see very clearly. Neck abscess also showed the same thing. Edematous brain parenchyma, invasive fungi in the Bavani trabeculae, necrosis of the periorbital muscle, and fungus identified. One fact was that I forgot to mention was a transcranial ultrasound after the catastrophic loss of vision on the second eye showed both ophthalmic arteries to be completely blocked. Now here we have a patient who has been discharged, who's totally blind, but she made excellent recovery otherwise. But she was ambulant at home, but she had draining sinuses from both eyelids, which was healing very slowly. This opened up various management challenges. So in this patient, for the first time in my entire professional career, we did consider whether a bilateral orbital exenteration was an option. On one side is a patient who has draining sinuses on both sides, possibly the necrotic fat coming out with infection, who's healthy otherwise, but with both eyes bilateral ophthalmic arteries being blocked. So obviously the healing is going to be very stormy, very slow. So I looked up at bilateral orbital exenteration. Yes, it has been reported. There's one report of a patient with squamous cell carcinoma even survived for 5 years. Potential benefits of the patient in this case, because she was recovering well otherwise, the draining sinuses, whether that could be healed. But challenges in performing the operation safely with good healing, I think that was very difficult to predict, because we could make, the cover the bony orbit with any tissue, but whether it would heal well was always, moot question. A detailed discussion of the mucormycosis task force was held. This is how all the draining sinuses healed up over time. And finally, in our case, the answer was provided by the passage of time and the healing process. And bilateral orbital exoneration is the rarest of rare options, and modern development in diagnosis and treatment may obviate the need for such a extensive and disfiguring operation in nearly all cases. So this needs to be thought of. The very fact that this needed to be thought of in this case was a very important challenge, and brings various medical dilemmas, practical consideration, deep philosophical and spiritual considerations as to what we are doing as physicians and surgeons, and whether we are basically going to do good to the patient or possibly harm the patient by undertaking such an operation. Thank you.
Thank you very much for bringing out this excellent, the real most difficult case of the session. And you have nicely brought out all the practical and the philosophical considerations as well. My takeaway from this is the importance of the KOH mount that actually provided the diagnosis and moving forward. And if at all you had to excentrate in this patient, you had decided for excenteration, would you be performing an excenteration or just debridement of the tissue and allow it to heal, sir? What would be your final decision?
Yeah. Basically, what was coming out was possibly necrosed fat, because fat, as you know, has a very high oxygen demand, and it needs good blood supply and oxygen supply. And that was completely cut off with the ophthalmic arteries being completely blocked. There was further areas where the fungus had invaded. So there was no way in which we could leave some tissue behind and remove some of the tissues also. So it would be an exenteration in any case, but covering the socket with skin graft, or because here we could not do an eyelid skin sparing exenteration. The skin itself was fairly badly affected. Otherwise, one would have to do a temporalis flap or something which is vascular, and which possibly my plastic surgeon colleague did consider, and doing it bilaterally. So all these things are virtually unsustainable in terms of the patient being able to live with that safely and comfortably. So that's
true.
Possibly.
It's one of the most difficult decisions. Sir, any comments, Dr. Ashok sir, Ashok Grover sir? With your comments, we'll move on to the next case.
Thank you, Ravindra. That was an excellent case presentation. Several unusual features which made the diagnosis difficult. To me, whenever rapid progression of loss of vision goes on the other eye very rapidly within a day or two, I haven't yet seen any other entity except mucormycosis so far. So that would have been my first diagnosis. But of course, with all the differences, all the complicating factors, there being no cause for immunosuppression, there being no significant changes in the nose or in the sinuses, that would have made things really difficult for anybody. Yes, as regards the exenteration, bilateral cases which progress that rapidly usually have a very poor prognosis. Somebody with that kind of intracranial and cerebral abscesses, I would be very, very reluctant to go ahead with any surgery like that. And I would much rather preserve life. I think they've done a tremendous job as a team to have the patient go out of the hospital live after all that she's had. Very few, I have seen hardly any patient survive who's become bilateral in a day or two. It's usually such a rapidly progressive disease that most of them succumb. And in addition, having abscesses and all the intracranial pathology and surviving through it is a great compliment to the team.
And this organism also takes longer time to grow, no sir, in culture? How did you identify the organism? Did you do culture for this patient, sir? Or does it make any...
Not culture. IOH, not culture. Culture is your
Microscope.
it takes time, right?
Okay.
It takes time. So either pathology, histopathology, rapid techniques, or direct staining. Just a couple of points here. Why we even considered is the fact that this lady had a fantastic set of children who cared for her like nobody else could, like cleaning her, taking care of her, holding her hands, making her walk around the house, etc. So they were the ones who, in a way, were driving and saying that if you can make her comfortable and the discharge goes away, maybe she's happier. So in this sense, what Dr. Grover mentioned, that as doctors we were reluctant, but the patient's attendants were pushing for it, and that's very unusual for somebody to ask for such a disfiguring surgery. So it's
So
learning.
any underlying cause for immunosuppression that you could pick up with your team?
Looked at very carefully by all
Bilateral disease is
bilateral, very
is a
unusual,
sure indication of, yeah, very unusual.
but otherwise healthy. And we were still learning. Actually, this came little early in the mucormycosis epidemic, when the north and the west were actually experienced with cases in the first wave itself. But this was at the start of just at the start of the second wave, so we were also possibly, the index of suspicion was also possibly not as high, and so maybe that was also responsible.
So thank you very much, sir, for this wonderful presentation.